Hi, and welcome to the December 2025 issue of IGIE. My name is Phillip G., editor for IGIE's section on historical considerations. A polymath is a person with vast knowledge and expertise across many different fields, who have the additional ability to see connections between different disciplines to create novel insights. Polymaths have existed throughout history, and medicine is no exception. Having gotten to interview these great masters over the course of this historical consideration series, I have noticed that the secret sauce of their success boils down to two very fundamental principles. First and foremost, they are guided by a strong and steadfast commitment to the patient. Second, they not only possess the intellectual curiosity and freedom to think outside the box, but they dare to take risks and step outside of normal boundaries in order to solve problems. We are therefore excited to tell the story of Dr. J. Pasricha, who is our distinguished guest for the Historical Considerations section of IGIE. Dr. Pasricha grew up in India, where his father was a general in the Indian Army and his mother was a schoolteacher. After coming to the United States, he initially trained as a pulmonologist before becoming a gastroenterologist. Through multiple subsequent experiences and opportunities, Dr. Pasricha morphed from an interventional endoscopist to a neurogastroenterologist, transforming both fields, from designing and publishing landmark studies on gut motility and visceral pain to inventing interventional approaches to solve these disorders. These original contributions to our field have included Botox injection for achalasia, the invention of endoscopic cryotherapy, and the original animal work on a novel concept that he called submucosal endoscopic esophageal myotomy, which he then applied to the treatment of achalasia. This ultimately became known as peroral endoscopic myotomy, or POEM, and the rest is history. Dr. Pasricha has continued to maintain an active role in innovation throughout his storied career, both in the realm of endoscopy and in neurogastroenterology, with continual research funding in a diverse range of fields spanning basic science, clinical research, drug discovery, and device development. He is one of very few interventional endoscopists who have simultaneously run a lab, striving to understand the molecular and cellular mechanisms of the enteric nervous system, visceral pain, and vagal neurobiology and its impact on the central nervous system. A central theme to his academic approach has been to not let oneself be defined by the tools being used today, but rather to become an architect to create the buildings of tomorrow. This disciplined but creative approach demands that one maintains a breadth and depth of knowledge as both endoscopist and scientist, in order to connect the dots where others may not have been able to do so. In other words, a polymath. Following multiple leadership positions at UTMB, Stanford, and Johns Hopkins, Dr. Pasricha is currently professor and chair of internal medicine at the Mayo Clinic of Arizona. With over 300 manuscripts and book chapters and over 50 patents to his name, Dr. Pasricha continues to maintain an active neuroscience laboratory at the Mayo Clinic. A true visionary and servant leader, Dr. Pasricha serves as chair of the NIDDK Gastroparesis Clinical Research Consortium and previously served as the founding chair of the AGA Center for GI Innovation and Technology. He is a recipient of the AGA Masters Award for Outstanding Sustained Achievement in Gastroenterology and designated as Master of the ASGE for his pioneering contributions to endoscopy. Dr. Pasricha, thank you so much for taking the time to do this interview. It's truly an honor and privilege. Tell us a little bit about your background and how you ended up becoming a gastroenterologist and an advanced endoscopist.
Thank you, Phil, for that very kind introduction. Well, most of what I've done, I guess, in my life or achieved in my life has been by accident. And I clearly became a doctor, not necessarily of my own choice, at least not back then. It was my mother who insisted that there should be at least one doctor in the family. My older brother managed to escape her clutches, and I unfortunately ended up fulfilling that dream of hers. And I will say I always wanted to actually be an engineer, and I had been selected for, at that time, electrical engineering, which was the forerunner of now what we call computer engineering at IIT Delhi. But I had to change my mind, and for a few years I struggled whether I had made the right choice. But now, of course, looking back, you can see the wisdom and forethought of your parents in selecting something for you, and I'm very glad she did. As far as gastroenterology is concerned, I think I've always had a liking for the field, but I actually first became a pulmonary specialist. Went to Tufts New England Medical Center, did a 2-year fellowship, and got certified in pulmonary medicine for the first 10 years. But right after I was just about to finish my fellowship, I was given a choice of doing another year of critical care, which was at that time just being incorporated into the pulmonary fellowship curriculum. And I felt I could do something different because I wasn't a big fan of spending all my time in the ICU. And as luck would have it, I applied for GI and I got selected at both the NIH and Johns Hopkins without missing a year. And I chose Johns Hopkins, and the rest, as I say, is history.
It truly is. And, looking back at your background, one would have never guessed that you went into pulmonary at first, or that you were an accidental physician, quite frankly. So your parents obviously saw something in you that you didn't quite realize at the time. But these are all very important exposures to have had, because it allows you to see the world a little bit differently than people who were born and grew up knowing that they were going to become a physician. I think it's allowed you to see the world from a different angle. So tell me a little bit about your experiences at Johns Hopkins, about your mentors there, including Dr. Tony Kalu, and how you ended up going into interventional endoscopy.
Yeah, so when I was selected to be part of the fellowship program at Hopkins in 1990, it was a very traditional track. It was a 1+2 first year clinical, second, third years in a lab. This is the time when Hopkins was populated by, giants in the field, Tom Hendricks, Ted Bayless, and amongst others, Mark Schuster in motility. Mark Donovis was the chair then. He had just taken over from Tom Hendricks a couple of years ago and was bringing Hopkins GI into the modern era by expanding the endoscopy operation, and had hired Tony Kalu to be, in fact, their lead therapeutic endoscopist. And Tony had just been there about 2 years when I started, and believe it or not, he wasn't in favor of selecting me for the fellowship because when they met as a group to decide my candidacy, Tony raised an objection. He said, he's done pulmonary. He's now wanting to do GI. He can't make up his mind. He'll probably do cardiology next. Anyway, so I think in the end he agreed. And I was on track to pick a lab. And then in the last few months of my first year, Tony came up to me and said, you're really good with your hands. We're expanding our therapeutic endoscopy. I'd like to start a fellowship, and you could be the first fellow that we'll train. And it was an exciting offer. It was not quite what I had planned to do, but I said, yeah, sure, we'll do it. It's just procedures after all, but I want to do more than that, and I want to start a lab where we can actually test hypotheses scientifically. Whether they be endoscopic hypotheses is irrelevant. We must approach this scientifically. And Tony agreed, and the two of us then went to the chair and asked for some resources. And as I said in the article that you'd written, we got a sum of $5,000, and we walked out feeling like we were in seventh heaven. Wow, we got $5,000. We can go to town with this. And of course, we didn't realize how little we could do with it, but Hopkins to his credit gave us a lot of other support, and we were able to set up an endoscopic lab, got some old scopes. I learned how to anesthetize pigs. I don't know if you've ever done that. It is quite a task, And, you know, you got to find the vein in the ear, which is very difficult because the skin is so thick you can't get it anywhere else. And it's okay when they're young. They're little cute little piglets. But when you try that, when they grow up, and they're like 5 times their size, they're chasing you, not the other way around. So there was a lot of learning that way as well, learning how to handle animals, learning just, you know, the operational aspects of being a lab tech. That's
Right.
essentially was the job, being lab tech, being fellow, being investigator. And but that lab then allowed us to do a lot of things and test a lot of hypotheses. So just to, you know, Tony's credit, he was a great mentor. He spent a lot of time with me. He taught me a lot of endoscopy and how to push the boundaries in terms of taking risks with procedures. And we used to do crazy stuff back then. These are the days when lap chole was just being introduced. I don't know, you know, this is way before your time, early 90s, and everybody was jumping on the lap chole bandwagon without necessarily all the skill sets. And they would take a weekend course somewhere and then start doing it in their practice. And we would get at least 3 times or 2 or 3 times a week serious bile duct injuries. We'd go in there and, you know, shoot some dye up the common bile duct, and all you saw was a cutoff. And we had to be really creative. We were actually shooting guide wires through that and hoping to get to the other side blindly, and we were able to do it. So that's where you learn a lot of stuff. It's under those kinds of circumstances where you don't have a choice. You just got to do it. And it is very, very, very terrific learning experience for me. And then, of course, there was the science that we were doing at the same time. That's when I got started on the botulinum toxin. And I'd, you know, most people just think about the New England Journal paper, but before that, there was a paper in gastroenterology where we tried to show the mechanism by which it works, because it's never really been tested in GI smooth muscle before.
It's very interesting, and you know, it's some of those stories came about through your contemporary colleague Sergei Kantsevoy as well, who also mentioned very similarly the history of laparoscopic cholecystectomy in that same time period where you guys crossed paths at Hopkins. One thing that you bring up that's very interesting is, you know, how you view endoscopy, right? It's more of as a tool, and you guys kind of started a lab together. What were your interests in gastroenterology when you first started?
I think the richness of field in terms of the different organs, you know, we lump them all under gastroenterology, but as you know, they could be specialties on their own, and in fact are subspecialties already. But that was intellectually very stimulating, and coupled with the fact that, unlike a lot of internal medicine specialties, including pulmonary at that time, where bronchoscopy was only diagnostic, there were things that you could do in terms of immediate impact with the endoscope, even though we were still not completely where we are today in terms of realizing the full gamut of procedures that we could do. So I think it was that combination that drew me there. But when you're young, you don't think so hard about these things. You know, you're kind of immortal and invulnerable, and you just say, okay, I'll take a plunge and let's see what happens. Maybe see if I land on my feet. So I would hate to tell you that I agonized for weeks and months thinking about it. I said, okay, here's a chance. Let's do it.
Or more so, I guess there was a patient who had a need, right? And I think you just kind of try your best and see if you can deliver something to help the patients out.
Yes, eventually. I mean, I think that you do that in every specialty, but in terms of why I chose GI.
Oh, yes.
But, you know, yes, then of course the Botox thing was, and others, you know, that we did, the cryo. We were the first actually to do a randomized controlled trial of pure of sphincterotomy
Uh-huh.
using blended coagulation cutting or pure cutting, and we showed that pure cutting was better in terms of preventing post sphincterotomy pancreatitis. I actually presented that at the plenary session at ASGE at DDW in the early 90s. One of those papers, like lots that I never found the time to push it through to publication, but still there's an abstract.
So, let's actually talk a little bit about. We mentioned Botox a couple of times in achalasia. Now, what initially drew you to the field of achalasia, and then subsequently to neurogastroenterology? Well, what drew you into that specific disorder, and coming up with the treatments for this?
Well, that's another one of those accidental stories, right?
Right.
So I was a first year fellow, Tom Hendricks, on the consult service, and there was a patient with achalasia, and pretty straightforward case, and pneumatic dilatation was kind of the standard treatment. And we went out with the Brown-McHardy dilator, and Tom was teaching me how to inflate and how to watch for and the fluoroscopy. And we did everything perfectly, and patient developed chest pain subsequently, and we did a oral contrast study that showed a leak, and he had a perforation. And we watched him, and of course, as a fellow, you have a major complication like that. It's scary.
Right.
Also makes you really think about what you could have done differently. Patient did well, actually, and most of these perforations actually end up doing well with conservative treatment. And that sort of never left my mind. Can't we do better than this? And it was about the same time that, my two girls, they were 2 and 3 years or a year apart. And my wife, brave soul that she is, would take care of them during the day. When I would come home at night, it's my job to tuck them in and then, stay with them because they would always be getting up at night. And so in those days at night, I would actually retire to their bathroom, lie down in their tub with a couple of pillows and a stack of journals, and just start reading rather than going back to sleep because I knew I'd be woken up in an hour or so.
Uh-huh.
And I still remember that one of those nights I was reading the New England Journal, and there was this article on medical uses of botulinum toxin, and it really caught my attention because what the heck, botulinum toxin? I don't know if you've ever read Alistair MacLean, a famous novelist for Where Eagles Dare, Ice Station Zebra, British novelist. And he had a book called The Satan Bug, and that was all about botulinum toxin. So it had those sort of very romantic connotations of me, deadly but romantic connotations. And so I said, let me read it. And I read it. It was fascinating. It was Alan Scott's work with strabismus and all of the, the skeletal muscle dystonias. And I enjoyed reading it. Joe Jankovic was the author. I kept it aside, and then I said, "Where is the stuff on gut? Why was anybody talked about it?" I went back and read it. Nothing. And then I connected the dots, and a lot of, I think, good innovation comes from connecting the dots. Keep your mind open. You see the dots, and then you just draw the line. And so the thing is, well, here's a tight sphincter. They have a tight muscle in the eye. They put Botox. It worked. Maybe this will work. And it was a crazy idea in some ways, but very sound scientifically, right? There's no reason to think it wouldn't. It wasn't like it was, going to kill somebody because people were already doing it in other parts of the body.
Mm-hmm.
So that's when I started thinking about it and, started doing my diligence and trudged to the library. Those were the days before PDFs and electronic
Right.
copy. You could trudge down to the basement and go to the copying machines and go to, you know, Index, the Medicus Indicus, and
Yep.
look up all the references manually and write them down. And so it took me a month or so to do it. And then I
Hmm.
started writing a protocol for testing this in animals because I realized you had to do it in animals first.
Right.
And that's kind of how it started. Uh, it wasn't easy. Well, acceptance of that idea wasn't easy. Let's put it this way. The
Hmm.
project itself wasn't that tough.
And subsequent to that, yeah, I guess that really kind of cemented your interest in neurogastroenterology, is my understanding, right? Because I think you had, yeah.
Not quite like that. I mean,
I mean,
yes.
you'd obviously done a lot of pioneering work in a lot of other spaces as well, right? Between ERCP and blended currents and stent design and
Uh,
stent development, and then there was a cryotherapy thing. But nowadays, when I think of you as like a big motility person, where you had blended successfully interventional endoscopy and motility. I think I view you as like the early days were the achalasia days with Botox injection, and then that led to POEM. And I guess that really kind of foster like a interest in the enteric nervous system and motility.
uh, yes and no. I mean, I
Uh-huh.
obviously I had to read about achalasia to understand achalasia
Right.
when I started doing that, and I knew a lot about achalasia. But you know, if you look at neurogastroenterology, and it's one reason why everybody's attracted to working in the esophagus. It's very straightforward. It's not too complicated. There's so many patterns you see, and it's so easy to do the tests,
Hmm.
and you stop. And a lot of the motility folks don't want to go below the lower esophageal sphincter for that reason. So it's not difficult to understand conditions like achalasia or
Sure.
esophageal motility. So that doesn't necessarily make you a neurogastroenterologist.
Hmm. Right.
It makes you an esophagologist. And I didn't think I had any ambitions at that time to become a neurogastroenterologist. But again, this is the accident theme, right?
Right.
So I was suddenly catapulted because of the botulinum toxin
Uh-huh.
into, regional prominence as the go-to guy to send patients with achalasia.
Right.
Because generally community practitioners didn't do those procedures.
Hmm.
So I started getting a lot of those. And people assumed because I was dealing with achalasia, I was also a motility expert.
I see. So it's assumption.
And so they started sending me non-achalasia
Uh-huh.
patients, not just for the esophagus, but stomach and,
Uh-huh.
colon and all of that stuff. And I didn't have a clue. And actually, at that time, Marv Schuster, who was the chief of GI at Baby, which is, part of the big family of Hopkins, and was a big guru in motility, again, because of my work in achalasia, asked me to join his group, motility group. And he said he'd teach me everything in motility. And I started there, and I did learn a lot of procedural motility, like manometry and stuff like that. But it takes a lot of time to really understand how to treat these patients and how to take care of them. And frankly, even after all these decades, I'm still struggling, and I think a lot of people will tell you they still struggle with that. So it was really patients would come to me, and I would try my best to do things. I learned from the patients.
Hmm.
I didn't give up on them. And as I started taking care of these patients, I realized how little I knew. And not only how little I knew, but how little was known in the literature as well. And that's when I said, I'm going to have to start going back to the lab to understand or test some hypotheses. And one of the areas I was very interested in was pain.
Mm-hmm.
These patients, almost all of them have some form of pain. And back then I was a therapeutic endoscopist, and the only way I knew how to deal with pain was to cut something. And we ended up cutting a lot of sphincters, 40. And the biliary sphincter, cutting the biliary sphincter didn't help, then we'd cut the pancreatic sphincter, we'd cut both. And if that didn't work, we'd put stents in both. It was a rabbit hole.
Right.
I checked myself one day. I was sitting there in my clinic waiting for the next patient. And I said, why are these patients coming to me? They're not coming to me because they think their sphincter needs to be cut. They're coming to me because they want somebody to fix their pain.
Right.
And that's, the first time I recognized how important it is to understand the true unmet need. If you look at these patients with the lens of, therapeutic endoscopist, you see a sphincter waiting to be cut. But if you really see where the unmet need is, it's this pain.
Right.
Then that was kind of a epiphany of sorts. And I said, okay, I get it. And then the logical question was, what do I know about pathophysiology, the pathogenesis of visceral pain?
Mm-hmm.
And I took out a pen and a piece of paper and I said, let me draw the anatomical wiring from the gut to the brain with respect to pain signaling. And I started with the gut and drew a little axon, and then I stopped because I had no idea.
Mm-hmm.
And I said, I got to stop doing this. I can't take care of patients with pain if I don't even know.
Right.
Circuit is. What am I doing? And so I went back. And then after I moved to Galveston, I set up a lab where first project was dissecting out the dorsal root ganglion neurons, the sensory neurons, the spinal cord, studying them in vitro, and then building animal models to mimic the kinds of pain we would see. So that was the lab where we created one of the first really, really valid models for irritable bowel syndrome, which even today is widely used. Model for chronic pancreatitis pain, model for functional dyspepsia. Those are the common pains that we see. And with those models and that understanding of the cellular and molecular basis, we could then start teasing out what possible targets we could have for pain treatment. So that was kind of how I got into this. Motility, became a neurogastroenterologist. Again, was not a card-carrying neurogastroenterologist to begin with, was not ever formally trained in neurogastroenterology. And, but here I am.
No, it comes from a tremendous amount of intellectual curiosity and I guess in some ways a bit of academic risk-taking, right? Because I feel like, correct me if I'm wrong, but I feel like the natural order, I guess the natural history of an endoscopist is as an endoscopist goes deeper and deeper into interventional endoscopy over the course of their career, they wind up more and more interventional and farther away from things that make them uncomfortable, like some of the basic science and basic gastroenterology and, like questions like what you have taken the bold leap to try to understand, right? So that kind of really sets you apart from all the other people who are card-carrying ERCPists, for example, right? Like a lot of us, you're right. We see the patient, we see a sphincterus waiting to be cut, or we see the patient, we see a bile duct that's waiting to be stented. But you view this a little bit differently as, what is their fundamental symptom or their fundamental complaint, and you viewing that as the unmet need. That's very different, I think. And I really do wonder, like, what is it about your background that has trained you to see it this way?
Well, thank you for saying that. I don't know I'm that different. I have,
Well, none of us have replicated what you do.
but it's not that difficult. It's we get caught up, right?
Right. We do.
And we get sort of stuck in our grooves.
Right.
Uh, and as you said, that's a comfort zone and becomes a
Yeah.
comfort zone after some time. And it's, why bother? Things are going well. Typically, the therapeutic endoscopists are, the top of the pyramid in GI, you know, always in demand. Instant gratification. What can be
Right.
better than pulling a stone out, taking a picture and showing it to the patient? This is what was your problem.
Right.
Great. And that's why young people are attracted to it, because it's that, it's that kind of satisfaction that you don't get taking care of a patient with chronic pain or
Right.
chronic disability. So, you have to look at it this way. What's this about, right? Is this about you or is it about the patient?
Right.
About you is fine. Nothing wrong with it. You should do it. But if you started off agnostically and saying, I'm here to help patients, then you got to pay attention to that aspect as well, right?
Yeah.
You don't necessarily have to do anything. I mean, you can't be a gastroenterologist and suddenly become an anesthesiologist, right? So we're not asking people to sort of change their stripes. We're just saying, if you keep your mind open,
Mm-hmm.
that something other than what you are seeing, it'll actually create opportunity for you within your field.
Yes.
You don't have to stop being a therapeutic endoscopist. You can just use that tool that you have in a way that you didn't think about before, because it's a very powerful tool. It's a tool that we still haven't fully exploited. The ability to get into any part of the gut, in the peritoneal cavity, and within the lumen, wherever, and deliver stuff or sample stuff. That's a terrific tool. But we've only been doing stuff that we've been taught to do and said, this is it. And there's no point doing any of that other stuff. And that's fine if you just see things in black and white in terms of where the problem is. But if you open up your mind, then you start seeing the gray areas.
Right.
And you think, maybe I can use this tool for that, because I have the tool. I'm there. I go there every day. I come back without, doing anything. So that's the point, right? It's
Yes.
you go to a forest every day and you can come back with an empty basket. You're taking a basket every day, but suddenly somebody says, hey, there's an apple tree there. Now you start gathering the apples and bringing them back. That's kind of the way you sort of have to think about it. You have to see the patterns, and you got to start opening your mind up.
And I think a very relevant example of where this was put into practice was the development of the animal model for poem. Right, it's kind of thinking outside the box. So, actually, tell me a little bit about how this came about, because it had to do, obviously, with also meeting the right people too.
Well, it's again, these are the things that you say are accidents, right?
Right.
So,
But true. But you also, I think what I've known about you is there is a component of accidental and a component of luck. But I'm a firm believer that one creates their own luck in life too, by putting themselves in the right place at the right time.
yeah, you may be right. It is, and another way of saying that is connecting the dots. And
Yes.
some people have more of an ability to connect dots than others, perhaps. But I
Right.
think, I don't know whether that's true. I think people have not let their imagination free
Yes.
because they're generally risk averse,
Yeah.
have the confidence to take the leaps because they've been burnt. or it's just not comfortable. But I think that everybody has that ability.
Mm-hmm.
Look, you cannot get into a medical school in this country, or anywhere for that matter, if you're not on top of the class, you're bright as heck and creative as all can be. So that's what it takes to get into medical school. After we get into medical school, we tell people to lock that creativity up, throw it away, follow the regimen.
Yep.
And now you've got to figure out how to unlock that.
Yeah.
Once you do, it's fun. That's the beauty of it. It's not work. It's
yeah. It's
anyway,
like this. It's like this project.
Right.
It is
back
fun.
to our
You're right.
question about the point thing,
Yes.
right? So, as part of the Apollo project, we were, Tony and Sergey had pioneered notes, and everybody was kind of trying to push the envelope as to what to do with it. But a lot of our effort was also, how do we find a safe and secure method to get into the peritoneal cavity and then be able to seal it, right?
Mm-hmm.
So this is where Chris Costout was going, sort of getting into the wall of the gut, tunneling it a little bit, so not having a direct hole to the peritoneal cavity, but kind of having a side entrance that would allow better closure when you were done.
Right.
But in the process, it was very apparent there are lots of things to do. That's what I call the third space, right?
Right.
People...
The journey is just as interesting.
That's what, people thought of this just as a passage, but I thought of it as a destination. And when you think of it as a destination, you say, what can I do there? Say, muscle is right there. When do I need to cut the muscle? Achalasia. I mean, not rocket science, right? Yeah, smack your head simple. And so you do the animal experiments, and because I start off, like I said, with an endoscopy lab, very comfortable with doing animal experiments, very comfortable with doing manometry on pigs and dogs and all that stuff. And it's not difficult after that.
Right.
When I presented that DDW, that abstract, the editor of Endoscopy came to me and said, I want you to agree to publish this. We'll get it published in 2 weeks. I said, wow. That's how it happened.
And in the audience, it sounds like was Haru Inoue.
No, not there.
No.
So that later that year, I was invited to Australia at the, I think they had their Motility Society meeting in Adelaide, and I was giving a talk there. And Haru was giving a talk on something else, I think it was endomicroscopy, but I'm not sure. But anyway, I gave this talk, he was there. He came up to me and he said, I'm doing this. I have a patient waiting for me back in Japan, and I'm going to do this. I said, I've only done this in animals, right? He said, yeah, I can do it. And sure enough, he did it, and he emailed me and said I did it, went fine. And then, he just took off. He's an amazing guy. Actually, I was in Japan a couple of months ago. I had dinner with him and his wife. Lovely.
Yeah. No, he's fantastic. Now, by then, you had already left Hopkins and gone on to UTMB.
Yeah.
Tell me a little bit about changing institutions and kind of your academic journey, and what kind of motivated you to set up shop at UTMB, and then subsequently you went to Stanford and then back to Hopkins, and now you're at Mayo Clinic. Along the same lines of like what kind of guides your career academically and your interest wise, but what kind of guides you geographically, if you will,
I don't think it's the geographic as much as, I mean,
or the opportunities, I suppose.
I was never looking, you know, as geography as the first motivation, but
Uh huh.
I guess you can now see from the way I think,
Right.
for me, change is important. And otherwise, you get stuck in a rut. So
Yeah.
sometimes you force yourself. So you asked why can't other people do it? Because it's uncomfortable. Moving is not easy. Trust me, ask my wife. Uh, since we got married, this is true, we have moved house 17 times. Now,
Wow.
we haven't moved to places 17 times, but within places we've
Yeah.
rented, we've, moved out. That's a lot of moving.
Right.
And this last time, I said, no more moving. Here I am. So, what you say is you look at the opportunity and you say, what really motivates you?
Right.
And it's not true for, same is not true for everybody, but if you still have this desire to make an impact, particularly if you have desire to make impact in newer areas and newer ways, then you take that opportunity, and it comes at a cost. Yes, you have to
Yeah.
move again. But if you do it a few times and you do it a dozen times or more, like I've done, it's okay.
So it sounds like each time was really in search of a different opportunity. So not necessarily, I guess you can't really say like better or for worse, but it's just a different set of opportunities to grow yourself in different
Yeah,
ways.
so this is the thing, right? So there's a linear model for career growth.
Right.
You can do it all in the same institution, and you can do it the academic ranks from assistant professor to professor, or you can do it by organizational hierarchy, regular rank and file faculty, associate director, department chair, dean, right? Or some combination of those. And you can all do it in one institution, but if you're really, really expanding your mind, one, two, then the time often comes that no one institution is big enough for where your mind wants to go. And if there was, it would be the ideal place. But so then you say, where can I apply this now when I know I can't, for whatever reason, I've hit a ceiling here. And that's what you do. And you're not necessarily actively looking, you're not putting your name out there.
Right.
That openness to accept opportunities, then when opportunities do come, you can seize them.
How does one recognize the ceiling?
You're bored.
Okay. That's a fair answer.
You wake up in the morning and you say, okay, just got another 10 ERCPs today. Well, how many variants can there be?
Right. Okay. That's a very fair answer. I want to ask you this. So for you, I think we've kind of established that's a very curious person, and you've obviously have really put your creativity to work. One thing that sets you a little bit apart from everybody else is, as opposed to other people who publish routinely, you patent routinely. So tell me a little bit about this approach to patenting things. I would say I would submit that a lot of my colleagues don't even have 50 publications, whereas on the other hand, you have 50 patents or more. So walk us through the thought process and the mentality. And actually, from a broader perspective, how do you take an idea from start to finish?
So that's a great question. And the whole, at least in my mind, reason for doing research in medicine is to help patients.
Right.
And whenever you find something that has the prospect or the potential for making an impact on patients, it could be a diagnostic, it could be a therapeutic, it could be a drug, it could be a device, or whatever. You can't assume that it'll make its way to patients. Even if you could make it in your garage, you can't sell it from your garage. You'll be shut down in a heartbeat. You got to get to the market. That's the way healthcare works.
Right.
Your idea has to be a product in the market for it to reach patients. So, as opposed to, being purely transactional business person, as medical professionals, we have to realize that while commercialization is not by itself the goal, it is essential to make an impact on patients. So now you have two choices. You either say, I'll just keep doing, maybe somebody will pick it up and commercialize it. Or you say, I started this because I wanted to make an impact on patients. I think it's a really good idea. And so I need to be engaged with how to get it to patients, i.e. I have to be engaged with getting it to market, i.e. I have to be engaged with commercialization. So if you really got that in mind, then you have no choice but to understand entrepreneurship, commercialization, at least elements, enough elements for you to know what you're doing.
Right.
And as part of that, the first thing you realize is if you don't have anything to protect, nobody's going to invest in it, because they're not going to invest in something that anybody else can make. Now, that is a transactional perspective. Unfortunately or fortunately, you have to depend on those kinds of people,
right,
who need to make a profit because they need to get a return on investments. It's not a bad thing. The way economies work. And by the way, these venture capitalists, everybody sort of looks at them and sort of has a negative impression. Guess whose money they're using for those returns? Yours and mine. It's our retirement money that goes in part to some of these portfolios that VCs have,
right?
Because it gives them above market return. So people forget that it's actually our money that they're investing in us in some ways. Broadly speaking,
right? Indirectly, yes, yeah.
So it's a very interesting world. It's a fascinating world. You can get carried away and become too caught up in the transactional piece. I think if you keep your head on you, realize where the boundaries are, but also fully understand that process, then people can't take advantage of you. They can't hijack your product.
Right.
They can't make it something other than what you intended to be. So it all begins with intellectual property in some ways. And so patents are important. That's how you get people interested in talking to you.
On that note, I think a very relevant example that we all would learn from is tell us about Apollo and how kind of that came to be, going from idea to patents to eventually to commercialization. Obviously, you've been involved in numerous small ventures here and there, both small and large. But I think one that all of us would relate to would be Apollo. So let's talk about that as an example, and then we can certainly branch off to other things that you've commercialized along the way.
Yeah, the Apollo story has many examples,
right?
Which are important for people to understand if they're interested in following that route. So the first is sort of the classic feel-good story. A bunch of people came together, had nascent ideas, connected with engineers. Those nascent ideas became refined, became physical embodiments, tried, tested, and eventually made its way to patients. And it's been very gratifying for the Apollo founders, including myself, to see that happen. The other example and the other story here is, don't think you're going to make a lot of money.
Right. I think a lot of people don't understand that part.
We have, 20 years of Apollo, I think, close to that. I would have made more money with my investment sitting, or the money I had put in, sitting in a CD or in my bank. Okay? But that wasn't the point.
Right.
And by the way, the person who made the most money were the people who joined in the last 2 years of the company before they sold it to Boston Scientific. And so it's not fair. So
Right.
don't go into this thinking, wow, it's all fair. Well, you shouldn't care about that as much.
Yeah.
Because if you want to do that, if you want to go after that transactional piece and say, I want to get my cut there, then switch sides. And people do that. They go completely to that side. And that's okay.
Mm-hmm.
But if you want to remain here, you want to continue to work with patients, be happy that your ideas made it.
Right.
All the other stuff is a bonus. Sometimes it happens, sometimes it doesn't happen. It doesn't all, some people do make out okay. Some people don't. But I'm just saying, separate in your mind those two components, the business part from being a vehicle for your ideas.
Yeah, absolutely. And how long did it take for Apollo to really kind of go from ideas to commercialization?
Apollo was so we started the Apollo project in 1998, right?
Mm-hmm.
So there's Olympus who initially funded that, and I think it was 3 or 4 years at least of Olympus support, and they withdrew the support, and they gave us back pretty much all the assets that we had invented. And as I said in the narrative, we got Dennis McWilliams interested as he was doing what we call an entrepreneurship in residence, entrepreneur in residence, EIR, with a local VC company in Texas. He got interested, started raising money, and a lot of the Apollo people were two minds whether they should go with a VC, up to the VC, but at the same time we've been trying to do this on our own and hadn't really had a lot of progress. So in 2007, the year I moved to Stanford, 9 years after the Apollo project started by Olympus, was when the company raised its first Series A. A very successful raise. I think it was close to 10 million or so. I can't remember the exact amount. At that time, it was a pretty big amount. But from then, 2007, it took another 10 years or so before the product started actually getting into the market. So we're talking 20 years, right?
Right.
I would say is slower than average, but not that much slower.
Got it.
10 years is about where you should be able to find out whether you're going to make it up. So from 2007 is when the company started, we were on track, 10 years, but that didn't take into account all the work that was done prior. But again, you can't make a lot of progress without real money.
Right.
With real C-suite professionals. You think you know it all, but you don't. You're primarily a medical professional.
Right.
You should stick to doing what you know best. So you can't really start companies and raise that kind of money and put processes and operations in place. That's where you need these the bankers, and you need the management people. So I think for 2007, 10 years, we did pretty good.
It's pretty good. Have you had any ventures that have gone a lot faster than that?
I personally have had ventures where people have bought out the interest very quickly,
Ah, okay.
like licensed it out or acquired the
Uh-huh.
rights. But taking a company from scratch to exit is not easy.
Right,
It's not, usually it's not fast.
right.
Again, remember, I am not a card carrying business person.
Right.
I'm no desire to be. And I am dependent on the card carrying business people. And this is where it's really important to know enough about the business to pick the right partners.
Correct.
And that's not easy.
Yeah, absolutely. Let's talk about something else that's not easy, and that is inspiring the next generation. So, in the last part of this interview, we'll talk a little bit about how you inspire others. So, I have a question for you. I am a father, as you are, and it has not gone unnoticed that your daughter has also become a gastroenterologist and has become a neurogastroenterologist. Tell me a little bit about how that came to be and how you influenced the next generation. Because to be totally honest, in our field, there are many of us whose kids do not wish to go into the same field that we went into because, they kind of watch their parents grow, as they were growing up and seeing all the long hours and seeing all the hard work, and they're kind of put off by it. But on the other hand, you've managed to inspire the next generation. So tell me a little bit about teach me about parenting, about fatherhood.
I wish I could. I'm not sure I'm the right person to talk to you
Do we
about.
have to interview your daughter for this?
Probably, but I'm not sure I'm your ideal dad or father. I was also very busy with my
Right?
kids. A lot of the burden was on my wife's shoulders, and without her, I don't think any of the kids would have turned out the way they did. I was not an absentee dad. I was there, I think, for the critical moments. But what I did, perhaps, that may have helped them was make my work seem like fun.
Mm-hmm.
And I would tell them stories about what I did at work. And I would bring them to work sometimes, but I would also tell them stories. Take them to the big labs. I think one of those experiments we were doing was looking at HIDA scans in pigs in the gallbladder, and we were doing the nuclear medicine thing. My daughter came in, and the pig was under anesthesia, and I was behind the computer looking at the images. And then, I don't know, it's made a big impact on her. She went to school a few weeks later on show and tell, talking about what the dads do or the parents do. So my dad is a big doctor on the computer and makes them better. So I used to actually, ridiculous, right? I used to bring back my endoscopies,
Mm-hmm.
videos. And I would say, here, this is what I did. I went down the stomach from inside and things like that. And they were young, like 4 or 5 years old or
Uh-huh.
something. And what are you doing? But it it broke down the barrier to my world for them.
Right.
Because I wasn't, getting up in the morning, going to some black box, coming back at night.
Right.
They could relate to what I was doing. Anyway, I told my daughter she wanted to be a physician when she was a little one. So I had 3 kids. This was the one I wanted. The others 2 never. She said, I'm going to go. She was like 8 years old, and people asked her, "What are you going to do?" She said, "I'm going to go to Harvard. I'm going to be a doctor." People laughed and smiled and say, okay, all right, good job. Anyway, that's what she did. Then I told her, don't go into GI. She went to GI. I said, don't go into neurogastroenterology. She went. She says she did it because it seemed like so much fun. That's why I'm telling the story.
Mm-hmm. And I think that's actually a very profound story. A lot of us could learn a lot from what you just said. And I really thank you for that. So, to wrap things up, I think that was such a perfect way to wrap up. But thank you so much for a very wonderful, very deeply insightful interview. I always close with this question. I ask this to everybody that we've interviewed in this series, and that is for not just advice and wisdom on the next generation. Of course, we touched upon that, but what advice do you have for future generations who wish to become as innovative as yourself, who wish to walk a similar path as you have?
Yeah, I mean, I don't think I'm special in a lot of ways. I am doing what a lot of people have the potential to do.
Mm-hmm.
And we talked a little bit about unlocking that creativity.
Yeah.
And find that key, right? Look for it. It's not going to come if you don't look for it. Look for it, actively look for it, and the world opens up. And it's a lot of fun. That's what I keep saying, the word fun. You're not doing this because it's some kind of noble mission for something, right?
Right.
It makes your life so much fun. It makes your work so much fun.
It brings meaning.
And even if nothing happens, just it's the intellectual, exercise. It's like doing a crossword puzzle, for God's sake. You don't have to get a Nobel Prize for doing a crossword puzzle. It's just fun. And make your life that kind of fun, right? Make your work crossword puzzle. You can connect the dots this way and that way. Very
good. I take it you do the New York Times one.
I used to do the Daily Telegraph.
Yeah.
There's a cryptic. I like cryptic. I don't like this non-cryptic ones. I don't know if you've ever done cryptic crosswords. It's the clues are not straight. It's not like 6-letter word for cheese.
Right.
It's very, very obtuse, and it's a lot more stimulating. But I stopped doing that a while ago because they don't make that, and they don't publish those anymore. I play bridge. Bridge is fun and intellectually stimulating. Yeah.
Very nice, very nice. Well, again, thank you so much for taking the time to do this interview. It's always a pleasure to catch up with you, and I always learn so much in all of our interactions that we've had, and really look forward to seeing this come out. I think it's you have a lot to teach all the rest of us in our field, and so again, thank you so much for taking the time to do this.
Thank you, Phil. I really appreciate all the work you put into this, and it's an honor.
Thank you.